That's good. So as you can see, we have the baby now. We still have our patient. And our nurse Coconut here is here. Okay. All right, so let's get back to it. So for this portion of the exam, we're going to have the patient lay down, and we'll continue with the inspection of the chest and the abdomen, as well as the legs. So if you would, please, Nurse Coconut, off you go. Good girl. Okay, thank you. Okay, all right.
Does the camera see me?
Yeah.
Okay.
All right, so lay down. So again, we just finished the cardiovascular assessment with no abnormal findings. And now we're going to expose the belly. And the difference with the abdominal assessment is that before you, you inspect, but then you're going to auscultate, because percussion and palpation can change the characteristics of the bowel sounds and alter your exam. So in this case, we inspect the abdomen. It's moving equally. There's no obvious palpations. On some patients, the abdominal ascending aorta can be visible and be benign, meaning palpation of the AAA can be it can be visible but benign. In this case, we can't see any palpations, and it's normal. So I'm going to listen now to bowel sounds, abdominal arteries, and report on my findings. So you want to do everything in a stepwise fashion, and I'm listening. Bowel sounds are audible. They're not hyperactive. Hyperactive bowel sounds can be indicative of obstruction or diarrhea or other abdominal maladies. In this case, the clicks are regular, they're not too high-pitched, and their frequency is not such to indicate an issue to me. I'm going to listen with the bell to the abdominal ascending aorta. And the renal arteries. Arteries going to the liver. And I heard no bruit throughout, no issues as far as any kind of obstruction or issues with the abdominal arteries or with the abdominal sounds themselves. Now I'll start with light palpation. So the patient is not reacting. There's no tenderness either on palpation or on rebound. I'm going to move to a deeper palpation. Take a deep breath. Exhale. So when the patient exhales, I can palpate the lateral margin of her liver. Again, a normal finding, but it's not hepatomegaly where you can feel it extending down below the bottom of the rib cage. We'll try again. Deep breath in and out. So I can palpate the one edge of the spleen. It's not always, you're not always able to palpate the spleen, but in this case I was able to palpate the lateral edge of the spleen again. There's no splenomegaly. And no tenderness for the patient as I'm pressing on deep palpation. If you were concerned about an appendix injury or inflammation, you would have pain here, or perhaps rebound pain on the other side when you pressed in and let out. That could be indicative of an issue with appendix inflammation. Can you extend your legs straight? We'll palpate the femoral arteries. Again, equal +2, easily palpatable. We're going to auscultate for bruits. So no bruit noted, and that would be especially important in a patient who had a recent cardiac catheterization or other procedure to access an artery. On a follow-up visit in your office, you would definitely want to be aware of the risk of a bruit, a thrill, which could be indicative of a hematoma, could lead to a retroperitoneal bleed if there was a non-healing issue in the femoral vascularity. So we'll continue down the legs, and we will palpate the popliteal. And the dorsalis pedis and the posterior tibial. And again, this patient has +2 pulses throughout. Nice and equal and even. No changes in color or temperature as you go down the legs. That could be indicative of any kind of vascular disease, whether it be venous in nature or arterial. So what we'll have now is to continue to assess the nerves of the legs, and to do so we're going to have the patient sit back up in our chair. I'll move this out of the way. Put this here. All right, now we're going to again check reflexes with our reflex hammer. We're going to have the, and what we want to do here is, again, why you do systemically, we will go top to the bottom to check all of the reflexes on the patient. So what we're going to do here is check the bicep reflex. So have the patient flex their bicep. All right, so you find the bicep tendon. It's going to feel like a cord. Have them relax it. What's that?
I'm sorry, I relaxed it.
Okay, relax. You're still holding your arm up. Say relax your arm all the way down. There you go. Yeah, yeah. Okay. And then we will find that spot, that cord where you found on the flex. All right. And you'll see a flexion of the bicep and the hand moving up. Now, with a loose arm on the back, they're hanging their arm loose, and you will find the triceps reflex. Okay. And then on the inner aspect of the arm, just above the thumb, you will find the third reflex of the arm. All right, and all these reflexes, these deep tendon reflexes of the arms are intact. So we'll do the same thing over here. The patient's going to flex, relax. Okay, we'll go loose arm. We'll do a tricep. All right. And again, just above the thumb. All right. All 3 deep tendon reflexes of the arms are intact. Now we will go to patellar, which deals with L2 through 4. All right. Okay. Both. And that's not hyperreflexia there. That's important to note. This one moved more than the other, but I struck this tendon better than the other. So you come back and you get the same response that you did before. So don't automatically jump to hyperreflexia and issues with electrolyte imbalance or whatever other stuff would cause that. It could simply be a need to reassess your technique. Next, we are going to have you take your heel and run it down your leg here. Okay, and same over here. Okay, all right, and then we are going to assess the plantar reflex. So we do so by extending the foot upwards. Relax your leg. Okay, and I felt the push down, so the plantar reflex is intact. Same thing here. Push down. Okay. So the plantar reflex, or excuse me, the Achilles reflex is intact. And then the plantar we will assess, and our feet grabbed over like this, okay, which is a normal reaction. Okay, all right. So plantar reflex is intact on both sides. Next, we're going to assess for her ability to produce proprioception. So can you close your eyes? Put your arms to your side and put your fingers to your nose. This finger to that nose. Okay? Now the other side. Okay? Now again. Okay? And one more. Good job. Alright. Now, can you, okay, open your eyes, good job. Can you extend your knee forward? Okay, and the other one? Okay, flexion and extension is appropriate in this patient. Can you stand up? Okay, can you do a small hop in place? Okay. Sorry about that. Okie dokie, we are off and rolling. Okay. Can you come to where I am and walk heel to toe? Just like this?
Sure.
Okay. Okay, and turn around.
Walk back.
Yep, walk back. Okay, perfect. Now go ahead and sit. Alright, now we're going to assess for her sensation using a sharp object and a dull object, and we'll do that throughout the entire skin. I want you to close your eyes and tell me if it's dull or sharp.
Okay.
Okay?
Sharp.
Okay.
Sharp.
Okay, that's why we do it on regular skin. Okay? Close your eyes.
Okay. Sharp. Dull.
Let's use a better
Sorry.
Okay. Alright.
That's dull.
Okay.
Sharp.
Okay.
Dull.
Okay.
Sharp.
Okay.
Dull.
Okay.
Sharp.
Okay. Do it here.
Dull.
Okay.
Sharp.
Okay.
Dull.
Okay. Now real quickly, can you squeeze both my hands? Grip strength is equal. Alright.
Sharp.
Okay.
Dull.
Okay.
Sharp.
Okay.
Dull.
Okay.
Dull.
Okay.
Sharp.
Okay.
Dull.
Okay.
Sharp.
Okay.
Dull.
Okay.
Sharp.
Okay.
Dull.
Okay.
Sharp.
Okay. Alright. Now I'm going to draw a symbol in your hand and I want you to tell me what it is. Okay?
Mm-hmm. A railroad track.
Alright, I'll give you a hint. It's a letter.
Oh, an H. Sorry.
It's an H, okay? So
Yeah.
you got that correct. And then I'm going to put an item in your hand and I want you to tell me what it is, okay?
Okay. It's a pacifier.
It's a pacifier, okay? Stereogenesis and graphophagia are both intact on this patient. She identified the object without opening her eyes and identified the letter without opening her eyes. And the last thing we're going to have you do is open your eyes, go ahead and stand up. Alright, and keep your hands out in front of you with your eyes closed. Okay, so there's no movement, there's no drift. This is the Romberg exam. There's no movement, there's no drift. So it tells me the patient's proprioception is intact. If the patient was an alcoholic, very often you would see the arm drift out or the hand would turn over because the patient requires the eyes to maintain proprioception. So with that, we have covered our basic head-to-toe health exam. Thank you for all your hard work this semester and for putting up with the insanity of my home-based clinic here. I look forward to working with you in the future. Thank you.
Thank you.